Hi everyone, welcome to Dr. Deepa's Learning Launch. I'm Dr. Deepa and I'm here to share with you another interesting cytopathology case. So this was the cytomorphology of a 50-year-old female patient who had come to the hospital with a history of 6 months of weight loss and difficulty breathing owing to massive pleural effusion. So the pleural effusion cytology revealed these highly cohesive malignant epithelial cells arranged in three-dimensional clusters that are very cohesive to each other that you're hardly able to make out individual cells here. And there is a smooth border right around this cell, and there's a faint halo around this cluster. So this is characteristic of adenocarcinoma of the breast origin. And this is called a classical cannonball cluster. If you see on a closer examination, you see that the cells show nuclear enlargement and high nuclear cytoplasmic ratio and some amount of coarse chromatin and some inconspicuous nucleoli. Sometimes the nucleoli can look conspicuous also. And at times you can also see vacuolated cells in this cohesive cluster. So in a patient with a known breast primary, this is seen only when it metastasizes. If the primary is unknown, you can pick up the phone, call the clinician, tell him that I'm suspecting a breast origin whenever you see this classical structure in your pleural effusion case. However, you have to make the final diagnosis obviously after a clinical correlation and after the radiology and after the IHC only. So you can suggest that it is likely to be of breast origin, and if it is a patient with already known breast origin, then you can give it as a Yokohama size classification 5 malignant. And the useful IHC markers for any such cases includes GATA3, mammoglobulin, and GCDFP15. So this supports a breast origin, while you can also do something like BERAP4 and MOC31 to confirm an epithelial origin. The tumor markers of mesothelial origin, which is WT1 and calretinin, which are classical mesothelial markers, are invariably negative in these tumors. So overall, the presence of a cannonball cluster composed of atypical epithelial cells and with significant nuclear pleomorphism in a pleural effusion is highly suggestive of metastatic adenocarcinoma. And with in an appropriate clinical setting, you can also comment that it favors this metastatic breast origin. Okay, so the reason I told you again and again when I was discussing this, that this borders are very smooth and not knobby, is because this is what it looks like when it is of mesothelial origin. If you can see in tough contrast with what it was in the last image, the borders are hardly conspicuous here and it is almost smooth and rounded, like it has one membrane over it, although it doesn't, but that's how it looks like. But this, on the other hand, is having a very knobby surface where you are seeing these lumps and bumps on top. So this is what a mesothelioma looks like, which resembles a mulberry and not a cannonball. So this, you need to understand I will again put up the previous image and this, so they are very contrasting. Do not get confused between the two cohesive clusters. So usually the carcinoma markers that are positive, that is in the epithelial origin, GATA3 is highly specific of breast and urothelial carcinomas. Mammoglobulin and GCDFP15 is specific for breast primaries. EpCAM and Claudin-5 are suggestive of carcinomas in the effusion. But in a case like this, which is having a knobby surface and not that much of cohesiveness as the previous image did, you need to do mesothelial markers like calretinin, then podoplanin and HMB1. These are the classical mesothelial markers which are invariably positive when you're seeing this knobby surface and not so cohesive cluster like the previous one which we saw. So you need to understand the difference between the two clusters. The first one was a cannonball cluster which had a smooth surface where you're hardly able to make out the difference between each of these nuclei that are cohesively clustered around. While this is that of a mesothelioma in which you're seeing a mulberry type of appearance, in which you're seeing a knobby surface. However, if you're in doubt, please go ahead and do an IHC, but you can pick up the call and suggest on the basis of the appearance itself to the clinician. So in case of diagnostic overlap, please make sure that do not use the diagnostic pitfall of using markers which can be positive in both. For example, sometimes adenostains can be positive in mesothelioma. For example, PAX8, CK7, AE1, AE3 can be positive. Similarly, mesostains that can be positive in carcinomas are WT1 and CK5 and 6. So never use these markers which will put you in further doubt. So use only the classical markers either for meso or for adenocarcinoma when you're in doubt. Okay, I hope you like this video. Stay tuned to www.drdeepa's Learning Launch for more such videos. Bye bye for now. This is me, Dr. Deepa, signing off today.